So thank you very much to Dr. Woodruff for the invitation to speak about fertility counseling challenges for transgender youth and families. I am part of both the fertility program at Lurie Children's and the Gender and Sex Development program. And as part of both of those programs, one of the things that I do is to see transgender youth, and I participate in the fertility counseling that they receive. This is something that Teresa referred to at the beginning, but the Oncofertility Consortium has really built a reputation as being a convener. And I think that in this particular aspect, it certainly has been for the work that we do. So in 2015 at this conference, a small but mighty group of us met and talked about fertility preservation and fertility potential for individuals who are transgender or those who have differences of sex development. And out of that, and many of those people are here today, and out of that, we produced this white paper, these proceedings of that working group session. And we addressed the risks of infertility, the fertility preservation options, the technical requirements, ethical concerns, and barriers to care. And this was a springboard for a lot of work that many people have gone on to do. And so we have made some progress, but there is a lot more progress that needs to be made. So when we counsel transgender youth about fertility, it is very challenging. We are talking to youth, so we have to teach them often about their body and about reproduction. We have to talk about the potential impact of the treatments that they may receive on fertility. We have to assess their attitudes about fertility and their expectations or their desires for future parenthood and how that may change over time, and integrate that with that of their parents. And then we have specific psychosocial considerations that for this population that may be different than others. So the first thing that I usually talk to patients about is basic reproduction. And most of them that we're talking to have sort of a decent understanding of the traditional method of having a baby. They understand intercourse. But a lot of them actually know very little about other ways to have a baby. So they don't really know a lot about assisted reproductive techniques. And so I really have to break it down very simply at the beginning and say, you don't, because a lot of these kids are not people who are necessarily interested in having a baby in the traditional way. And so they might say, well, I don't want to have children, but that's not actually the issue. It's the process to have a child that they don't want to do. And so you have to talk with them about what it really takes to have a biological child. And so my way of breaking it down very simply is that I will tell them you need a sperm, and you need an egg, and you need an oven. And those can come from different places, but these are the three basic things you need to have a baby. And the part about and I kind of joke about having an oven, but I think it actually has been very helpful with many of the patients because they have to understand that it doesn't have to be their uterus. It could be a partner's uterus. It could be a surrogate. But that actually, I think, has made many of the kids willing to listen when they wouldn't otherwise have thought that this was something they would want to do. So we have to talk about basic reproduction. And then we have to go on to talk about fertility potential and how the treatments that they may receive may impact their fertility potential. And so for this population, it's very much like it is for the oncology population, where we expect that they would have had normal gonadal development, normal germ cell development, but it's really the treatments that we're going to use for medical transition that may make them infertile. And so one of the things that we always have to talk about when we talk about transition for the gender nonconforming or transgender population is that every individual has different desires about what they want for their transition. Some people may choose not to do anything medically or surgically. Some may just undergo a sort of social transition, which means changing name, pronouns, how somebody dresses, their hair, things like that. But many choose to go further than that, and they choose some sort of medical and or surgical transition. And so that's the point at which we have to talk about fertility. So the timing of potential intervention for medical and surgical transition is shown here. Some gender nonconformity is expressed sometimes as early as 4 or 5 years old. So sometimes we're really starting to meet these families when children are very young. But there isn't any medical intervention that is even considered until they reach puberty, so until they reach a Tanner 2 stage of puberty. And at that point, we offer the use of GnRH agonists to suppress puberty. And the point of doing this at that stage is, number one, to prevent the development of secondary sex characteristics that may be undesirable for that individual. And number two, to give them time to explore their gender and what they want for their future. And using a GnRH agonist is a good way to do this because that's a reversible treatment. So it is preventing all of those pubertal changes. But if they would choose that they kind of wanted those spontaneous endogenous hormones to work, then we stop the GnRH agonist and puberty would resume as it would have before. So we use GnRH agonists as early as Tanner 2, and so we're using those during puberty to prevent pubertal progression. Now, some individuals may or may not have presented that early, but anybody who is in adolescence is somebody that could consider using gender-affirming hormones. So that's treatments like estrogen or testosterone. And then typically genital surgery is not performed until patients are adults. We're not going to talk too much about the surgical aspects today, really the effects of medical therapy. But which of these treatments affect fertility? Well, probably all of them. So that's what we'll go on to discuss now. So when you use a GnRH analog, you are preventing puberty, but you're also preventing gamete maturation. And so this can obviously cause a problem with fertility. So the GnRH agonists are going to pause gamete maturation. And if they stop using a GnRH agonist, then gamete maturation will resume. But if they don't, if they go on to use gender-affirming hormones, then what happens? So what happens to their fertility potential? And this is a big question right now. So obviously they don't have any spontaneous fertility potential because they don't have mature eggs or sperm. But is there anything that we could do using other hormone stimulation or assisted reproductive techniques that might allow for gamete maturation? And it looks like there might be. So this was recently published this year in the New England Journal as a correspondence about oocyte cryopreservation in a transgender male adolescent. So at age 14 years, he started pubertal suppression at Tanner 2 stage of puberty. And then at 16 years, attempted oocyte cryopreservation. So he remained on the GnRH agonist the entire time. He was given FSH and HCG. And monitoring for this was done via estradiol levels. There were no transvaginal ultrasounds done because that procedure was something that he really wanted to avoid. 5 oocytes were retrieved and 4 were preserved. During that time, he did experience side effects. So he experienced distressing vaginal bleeding and breast development, and the breast development regressed after 3 months. He also expressed depressed mood and brief suicidal thoughts, which resolved. Testosterone was started after the oocyte cryopreservation was done. And he was counseled that there had been successful oocyte harvesting, but there was a guarded prognosis for his fertility due to the number of the oocytes that were retrieved. And this is very exciting to see these results, but it also highlights some of the issues that we can see if somebody has to have hormonal stimulation, which is something they're trying to avoid. So the whole point of using the GnRH agonist was to prevent the development of secondary sexual characteristics and to try to alleviate some of the gender dysphoria that can occur. And we see, in youth that are going through changes in their body that don't match their gender identity, we see high rates of depression, self-harm, suicide, all of those things. And so we see that even during the 30 days that this patient was treated, he experienced development of secondary sex characteristics and depression and brief suicidal thoughts. So those are definitely concerns about the side effects of the treatment, but it is very interesting and exciting to think that it may be biologically possible to do this. So what happens if they've gone through their own puberty, they have mature oocytes and sperm, and then in adolescence they start to use gender-affirming hormones? So for transgender women, this means that they would be using an anti-androgen, typically something like spironolactone and estrogen. And we know that this leads to decreased testosterone and decreased spermatogenesis. And we know that for some transgender women who have used these treatments, they have in the future decided that they were interested in biological parenthood and have gone off these treatments and have been able to have children. But there's a lot we don't know about this. So in this review, they examined the influence of gender-affirming hormone therapy on testicular morphology in gender dysphoria patients. And the ones with the red stars, in those studies, they showed severe involution of spermatogenesis and Leydig cells even after they were not treated. But the ones with the blues, in the blue stars, those maintained spermatogenesis and normal Leydig cells. And some of these individuals had been treated for a year, and some of them had been treated for over a decade. And there doesn't seem to be a whole lot of pattern yet that we can see about whether it's the dose or the duration of treatment. So there are a lot of unknowns here about how estrogen and an anti-androgen are going to affect fertility for any individual. For transgender men, we treat with testosterone, and this may have effects on fertility due to a prolonged anovulatory state and due to this testosterone exposure. But we know that it often seems to be reversible. So I've put some information up here about 2 studies. And in the first one on the left, there were 13 transgender men in this study. 6 underwent oocyte cryopreservation before they started testosterone, but 7 had already been treated with testosterone. And for those 7, the mean length of hormone replacement therapy was 46 months. And then they compared the 2 groups, and they found that those who had used hormone replacement therapy had a lower peak estradiol level and a lower number of oocytes retrieved. But they did still retrieve 12 oocytes on average from those men. And 3 successful pregnancies were achieved from those who had previous exposure to hormone replacement therapy. And then in another study of 26 transgender men, they had mean length of hormone replacement therapy for 44 months, and 2/3 of them had been treated. And they actually showed that the mean oocyte retrieval was higher in the transgender cohort, and estradiol levels were similar. 16 of them were able to bank oocytes, and 7 achieved pregnancy. But I think one of the things that's important to note here is that we're talking about, in both of these studies, a mean length of treatment in the 40-some month range. And when I just explained how we now are treating youth, we're talking about starting treatment at age, as early as age 13 maybe. So these are individuals who could potentially have had 10 or 20 years of treatment before they might, in adulthood, decide that they were interested in fertility. And we don't know the effects of treatment that goes on for that long. So because we have all of these potential issues with infertility, talking about fertility preservation is a very important part of our care. And in our program, we really try to start this as early as possible. So at the very first time I talk about using a GnRH agonist, whether that's at 6 years old or that's at 12 years old, I start talking about the effects on fertility. And certainly when you have a 6-year-old patient, you are primarily talking to the parents about this at that point. But we do really encourage the parents to start talking about their children, about families, and to start to try to help their child think through what they might think they would like someday, whether they are interested in being a parent. And then it's also a very big part of the readiness assessment process that our mental health professionals do with our patients and families who are considering any type of medical therapy. But we have to talk about fertility preservation options. So if an individual is postpubertal, then certainly they have the option for sperm or oocyte or embryo banking. And that is a lot more straightforward, although we'll get into some of the complications that we have to think about later. But for those that are peri-pubertal, so those that are thinking, that are Tanner 2 and thinking about a GnRH agonist or getting to the point where they're thinking about taking estrogen or testosterone, there are a lot that we don't have the greatest options for that group. So we certainly can do testicular or ovarian cryopreservation in theory. We know that, just like it is for any of the other purposes that we discussed, that it is investigational. But there's also not very many places that offer this for the transgender population specifically. And so I know that they have testicular protocols at UCSF and at Pittsburgh, and I think I heard maybe Stanford. Anybody else? In Melbourne? Okay. And they have opened an ovarian protocol in Pittsburgh. But this is not available in very many centers for the transgender population yet. The individuals could also forego GnRH agonist treatment to allow in vivo germ cell maturation, but then this would require that they have secondary sex characteristics develop, and they may experience worsening dysphoria. And maybe they could remain on the GnRH agonist with some hormone stimulation at some point, which I mentioned, but is certainly still investigational and may have side effects. So these are kind of the options that we present to families right now, and they aren't really, we don't have a great armamentarium for them yet. So there are other psychosocial considerations as well. So what do we know about transgender adults and their desire for fertility and parenthood? We know that many desire parenthood. That may be biological, that may be by adoption. They may say that they would like to use a sperm donor. Some express a preference for fostering. But we know that they also believe fertility preservation should be offered, even if the desire to pursue it varies. And we know that many have regret about not having had these options when they may have started treatment. And then what do we know about the youth that we're counseling? Well, we know that just like the adults, their future parenthood desires vary. We also have to assume that what they think when they're 13 or 14 may be different than when they're adults. We know that their desire for biological parenthood is somewhat dictated by the family values that they have. We know that gender dysphoria plays a role. We know that they consider financial issues and high costs. And we know that they seem to have a lack of awareness about fertility preservation options and the procedures that are out there. And we know that they have invasiveness or concerns about the invasiveness of the available procedures and the potential psychological impact of the process. And so when we talk about that, what we're talking about partly is in these individuals, their gametes don't match their gender identity. So for some of these individuals, that's a big consideration for them. We know that there are complexities for them specifically about the procedures. So having to have frequent exams that involve their genitalia or having procedures like transvaginal ultrasound can trigger gender dysphoria and body dysphoria. We also know that the idea of taking hormones that don't match your gender identity can also be very upsetting. There have been some coping strategies that have been used for individuals who are undergoing fertility preservation procedures, and some of those strategies might be to focus on reasons that they're undergoing the procedure, to plan support from family and friends during this time, to use certain cognitive approaches to address body dysphoria, and then other suggestions have been things like using non-gendered names for body parts. And so that might be a discussion that has to happen with each individual about what would make this process easiest or at least less hard for them. And so what do we see in terms of actual fertility preservation in this population? In this slide, I've summarized 3 studies. And so the first was done by Lena Nahata and Gwen Quinn and others. And 72 adolescents were counseled within their medical visit about fertility preservation. And of those 72, 2 pursued fertility preservation. In another study by our group, led by Diane Chen, 105 adolescents were counseled within the medical visit, and 13 of them went on to do a formal fertility preservation consult. And of those 13, 5 actually went on with preservation. So 4 were preserving sperm and 1 oocytes. And then the most recent one here is from Julia Taylor's group. And they studied 66 adolescents. 52 had been counseled within the medical visit. 11 of those pursued formal fertility preservation counseling. 3 of the 11 attempted preservation and 2 of 3 preserved. So I think this shows us that there are people who are interested, but at least in these studies, there was relatively few actually pursued the whole process. But very different data comes from another recent study that was published here. And in this, they evaluated 35 girls, and 91% of them received counseling as part of their medical visit. Of those, 38% actually attempted fertility preservation. So that's a much higher number than what we saw in these other studies. Those who did not pursue fertility preservation gave reasons like not wanting children, wanting to adopt children, issues with the body, their process, or sort of the parts of it that they weren't comfortable with their body, and then the idea of being a father. So this is where I get at the idea of the gametes not matching gender identity can be something that individuals consider. And then I think there's actually a mistake in this graph because actually 9 out of the 12 who attempted were successful in preservation. So I think these black and gray bars should be switched. So 9 out of 12 preserved gametes, and for the 3 who were not able to, 1 was not able to ejaculate, 1 had azoospermia, and 1 had oligospermia and poor quality sperm. So we see here very different results, and so I think we don't really know what the future holds, and we don't know for any individual, whether fertility preservation is something that will be the right decision now or later for them. But we know that it's really important to have these discussions, and so it is. And so we have to figure out a good way to do this. We have to counsel about basic reproduction, about fertility potential, and then help somebody to think about their own desires. And so we need them to understand how it works and to figure out what they think and then be able to make these decisions. And so to do that, we need standardized counseling protocols, and we need patient decision aids. And that's something that is being led by Diane Chen, who's a psychologist in our program and received a grant to create a decision aid for transgender youth. And so many of you actually in this audience may have received or been part of a recent Delphi survey, which was trying to evaluate expert opinion about what should be part of such a decision aid. And so you can see results in one of the abstracts that is being presented here today. And hopefully that process and that decision aid is going to allow all of us to do better counseling and enable the individuals to make the best decision that they can make for themselves. And so that is where I will finish, but I wanted to prove that it's not always like this in Chicago, and this is actually Northwestern's campus not very long ago.